As you heard, I am not a psychologist. I'm not a professional in that area. I'm not a doctor. I actually had nothing to do with the mental health care system up until a few years ago. I'm a serial entrepreneur. I've started a number of companies for-profit. I've also had the pleasure of working for the federal government of Canada, both as the visiting economist in Ottawa for the Department of Finance, where my good friend Denis Gauthier and I had a lot of fun together, but also as the chair of the BDC, a great organization headquartered right here in Montreal. So really, I come from a very different world. My only interaction with psychology began in the mid-2000s when I was on the board of CAMH. So I was on the board of the foundation. I was one of those business people they put on to help raise money. And it was there that I learned all of the interesting interactions and what was going on in the mental health business here in Canada. And I learned about treatments. I learned about new ways of thinking about it, et cetera. And that was all interesting for me, and all the theory was interesting for me until October 18th, 2011. This is my day when life happened. We all have our days. But at 7:34 in the morning, I got a phone call from my sister telling my brother had dropped dead walking to work in Zurich, Switzerland. That probably would have been okay, except for in the previous 16 months, I'd had 2 heart operations. My dad had died. I'd had some other things go wrong in other parts of my life. And I have to tell you, 3 weeks later, I woke up and I turned to my wife and I admitted what I didn't really want to admit to anybody. And I said, hey, I'm depressed. And I wasn't like kind of depressed. I was like, I don't want to get out of bed today depressed. So I was seriously at that point when I woke up that day, 3 weeks later after this date, I seriously had a problem. And despite being the poster child, if you will, for how to get care in Ontario, and a lot of what I'm going to say here is a bit Ontario-centric, so I apologize for that, but that's where my experience lies. Despite being the poster child, board of CAMH, new to call, phone calls returned, at this level, money not a major issue, knew exactly what I wanted, knew all of the evidence-based treatment, I had a hard time finding treatment. I had a very hard time finding treatment. In fact, the first person that I went to, highly reputable, had a dog on his lap. Second person was clearly burning incense right before I got in there. Third person, I don't even know what that person was doing. It just kind of freaked me out. I left halfway through the meeting and went, whoa, I'm out of here. But it was hard for me to find it. And I said, well, gee, if it's something hard for me to find, who was literally the poster child, then it must be hard for everybody else. It must be almost impossible. So as I came through my depression beginning in the spring of that year, spring of 2012 actually, I began to think about with my wife, how do we change the system? After all, that's what we've done. We did it with Pathways, we did it with some other things we've started. How do we change the system? How do we fix what is broken? And by the way, am I alone? Like, what's really going on? And the reality is I'm not alone. 1 in 5 Canadians, according to the Mental Health Commission of Canada, will suffer from an issue this year. And I have to tell you, I don't buy this statistic at all, because when I suffered from mine, we have 4 kids, my wife and I, 6 people suffered from this issue. Not just 1, 6. In fact, my kids call it Dad's time. In fact, my kids all call me Sam now. I don't know if it was because they called that Dad's time and they try and differentiate between the two. But anyway, that was Dad's time. And that was the time when I was really hurting. And this was a primary, I was middle of the road, depression, kind of moderately severe at times based on the scales. And that came out. But the reality is that's also not the problem, is middle of the road depression. What the other problem is that the depression and the mental health, and someone else said it earlier, that goes along with chronic conditions. 1 in 3 cancer patients in hospitals are suffering from serious mental disorders. 40% of people with diabetes suffer from anxiety, and 30% from depression. That's 70%. By the way, those are additives. 70% of people with type 2 diabetes. And when you think about it, it makes sense. You come back from your doctor diagnosed with type 2 diabetes, you're not high-fiving people. Right? You're anxious. You're worried, is my life over what's going on? And you have 3 times the likelihood. And in fact, many people in the world think that this marketplace, the marketplace of mental health along with chronic conditions and other issues, is in fact larger than the others. But the problem is, despite all of this, 2/3 of the people in our country do not get treatment. And you're going to see a different statistic a little bit later on. This is out of the Mental Health Commission of Canada, highly researched number. I can tell you 2/3 don't get treatment. Now, if you have strep throat or you're suffering from something a little bit more serious, are you going to get treatment For sure, you're going to go to your doctor's going to do a swab, you'll get the test results back, you'll go on a prescription of whatever is appropriate for your disease. But in mental health, it's different. And it's different for a number of reasons, and we all know them, but it's different because we know that the gates exist. And whether these gates are real gates or imaginary gates, the gates exist. And the gates are all highly talked about. Cost, stigma, limited supply relative to limited supply professionals, and time constraints. Let me sort of give you just a quick overview of what this means. The cost, unless you get into the public system, and by the way, if you want to go into the public system in Ontario, that's no problem, but at one of the major institutions in Ontario, if you want to simply get group CBT, you're at a 9-month waiting list. In a LHIN out in the western part of the province, there's a 3,000 person waiting list, which is effectively an infinite waiting list in the public system, so kind of forget about it. You're depressed today, you don't need treatment in 2022. And if you want to go into the private system, our clinics range from $150 to $300 an hour, depending upon who you want to see and what level. And we are the second largest clinic operation in the country. Okay, so we have all levels you can see. And this is in an era where most of you who sit in this room have a health spending bucket, which by the way includes massages, includes everything else, of $500 to $1,000. And there's some progressive companies like Bell at $3,000, Manulife at $10,000, but the vast majority of us are covered by $500 to $1,000 plans. That means, and what we see in our clinics, is you can go see a person twice in November and twice in January. And then you're done for the year. And by the way, when you go, you've got to get up from your desk, and I did this, I call it the walk of shame. You got to get up from your desk, you got to go by all the people you work with, you got to leave at 2 o'clock to make your appointment at 3, to get back at 4:30. You do that, according to Health Quality Ontario, that just approved CBT for major depression, 16 to 20 times. And also, that's kind of the stigma that we live under, a theoretical one. What if you're a firefighter? And what if do you really want to tell your colleagues you're going to go into a burning building with, or you're being treated for panic? If you're one of the colleagues, do you really want to hear I'm being treated for panic? I mean, stigma is a very real issue in this thing. And it's with the supply of people. In Ontario, there are approximately 28 members of the College of Psychologists for every 100,000 people. In Toronto, if you're lucky, you're 49. The rest of the province, you're at 21 per 100,000. And in most of the province, you're at 0. You live in the north, you live outside of Sudbury at 50 miles, there's nothing there. And then, of course, we talked about time constraints. But we could solve these individual ones, and we could solve each one of these individuals without actually solving the problem, because the system itself is archaic. It is practiced largely the way it was practiced years and years ago. 1-hour sessions, in person, 30 minutes or 1-hour sessions, in person, despite the fact that the world has changed dramatically in the last 2 or 3 decades, despite the fact that demand has ballooned, which by the way is a good thing. People like in Ontario, the former federal minister of finance, Michael Wilson, people like Michael and like many other people have come out and talked about their issues, which makes it acceptable, which makes people go and get treatment, which is a very good thing. But we haven't kept up, and we still do a system that relies on in-person treatment. The best one of our psychologists can do, our workhorses, can see 23, 24 people a week, our workhorses. And those are people that are very expensive assets. So despite the fact, and you can throw bodies at it, you do it. So what happens? Well, what happens is people go see their GP. We studied 1,000 clinically ill people, hired an independent research firm to find 1,000 literally had been clinically diagnosed by a psychologist as ill. And one of the questions, there's a ton of data in there, but one of the questions we asked is, where do you seek for help? 85% go to the doctor, 58% go to their friend. Only 44 went to a psychiatrist. By the way, these obviously don't add to 100 because you go to multiple places. But what we have is we have a physical healthcare system treating mental health. And think about that for a moment. It's a system designed to get you in and out in 10 to 15 minutes. It has reimbursement codes that are designed on that 10 to 15 minutes. It has professionals, great professionals, trained to see if you have strep throat, not to see if you have panic disease, not if you have panic disorder. It's a system that is that is designed to do that. And even if you are lucky enough to get into a psychiatrist in Ontario, They'll see you once or twice, and then they bounce you back to your physician because they prescribe the meds, and they bounce you back. They're not really counselors. They're not paid to be counselors. And then if you want to go see a psychologist, I just sort of talked to you about what are all the wait times. And so it's not surprising that 1 in 10 of you, so there's 400 people here roughly, there's 40 of you on antidepressants in this room if you're average. Now, you may be above average, so there may be 80, I don't know. But the point being is 9% of Canadians are on antidepressants today. We are the 5th per capita largest user of antidepressants in the world. Our drug costs are increasing at 7% per year and have for a long time. And we are the 2nd in expenditure for pharmaceuticals per capita for prescribed medications in the world. A lot of this driven by, not all, obviously there's lots of other things. Mental health is not the biggest malady after all. A lot of this driven by the fact that 85% of people go first to their GP. Their GP has one bullet in their chamber, and that chamber is, let's go after drugs. Let's put you on fluoxetine. Let's put you on Cipralex. Let's put you on something. By the way, I've tried most of them. You don't really want to be on the drugs if you can avoid it. They have some interesting side effects. But that's what they're designed to do. Now, the good news is, as I mentioned earlier, people are starting to realize that there's another way. Health Quality Ontario just released a study for the first time approving, this was last year, approving for major depressive disorder cognitive behavioral therapy. And there are a number of evidence-based treatments. CBT happens to have been around for about 40 or 50 years. If you're interested, basis in Stoicism, actually a pretty interesting way it was developed back in the 70s and 80s and popularized, and also has almost 1,000 studies showing its effectiveness. But Health Quality Ontario, the standard-setting body in Ontario, approved it for major depressive disorder. Now that's the good news, because now what we're really doing is we're starting to have a system, we're starting to have a system that actually treats you as you need to be treated. But there's a problem. The 1 in 5, the math doesn't work. There are 4,100 members of the College of Psychologists in Ontario, and there's some more psychotherapists, so I'm focusing on psychologists here. If you were to treat only 20 or 25% of those people in the 1 in 5 and sort of cut down and say, yeah, we're not going to treat them all, you're going to do that and make a lot of things, you need 22,000 psychologists in a province that last year added 214 to the college. You can't do it. And by the way, it's $10 billion to $15 billion when you fully load these 22,000 psychologists, and happy to take you through the math if you're interested, but it's $10 to $15 billion in a province that spends a little over $50 billion in healthcare. And in a province and in a country, frankly, that really can't afford the deficits we already have. So, and not only does the math not work, we've got data from other parts of the world that says this may not be the most optimal, although it's working in other parts of the world. So if you take the Australia example, Australia back in, I think it was 2013, I may be off a year or two, so please correct me if I am. Australia decided that CBT was the way to go, so they allowed doctors to prescribe CBT for depression and anxiety, mood and anxiety disorders. Within 1 year, 7% of the population had a prescription. Now think about that. I can see 20 patients a week, and 7% of my people want to come see me immediately. It doesn't work. They shut it down. It overwhelmed the system. The system collapsed on itself. Conversely, an actually very good implementation of it was the IPT done in the mid-2000s in England, where they took a look and said, well, we need to re-engineer this a little bit, so let's do some light applications here on the front end. Let's do some talk therapy. They have to train, but they still have to train 21,000 people here within the next 2 years. And oh, by the way, they had 2,000 people drop out of the NIHS in the last 2 months. Not all psychologists, but they have to deal with the net effect, not the flow. But generally, they treated, last time I saw, about 1 million people and have pretty good results, but at enormous cost, at cost that we can't conceive of, and costs, frankly, we can't deal with. And that's all well and good, but you go back to that study that we talked about of clinically depressed people. We said, okay, so you got diagnosed, what'd you do? 75% said, we're not going to go see anybody, we don't want to talk to them. Mental Health Commission of Canada says 2/3. The reality is you can throw bodies at the problem. You can take the same thing we're doing today and throw more bodies at it. And let's say both of us are wrong. Let's say our study's wrong. Let's say that Mental Health Commission of Canada, again, a great organization, is wrong. Let's say it's only 60%. Let's say it's 40% of people that will do it. You still got 60% of the people aren't going to walk in and see anybody. And by the way, when I say they won't walk in, we were really clear. When we say see each other, that's in-person or telepsychology. We do both. We ask that question. 70% won't walk in the door. So you can design a system that works for 40% of the people that will actually bankrupt you even further than we're bankrupted today. And the reality is it all happens because, and this has been a general theme today, which I love to hear, is that the system that's delivering it is not patient-centric. It does not put the patient in the middle. It puts the patient on the outside. And the interesting thing about putting the patient not in the middle is that you then begin to focus on the issues around the providers and what works well for the providers. You know, in Canada, we essentially, and you know, I'm probably not a popular comment, we essentially ration healthcare by supply. We limit supply, we constrain supply. You have wait lists and such. That's why it takes a year to get a hip replaced in Ontario. We essentially ration healthcare by supply. We don't ration it by demand. Great, works effectively. It's a fair way to do it, but it doesn't put the patient in the center at all. And if you think about patient-centric ideas, this is not new. There's nothing new about being patient-centric. I can go back long history, like hundreds of years, where people talk about, the businesses would talk about customers and such, but let's just pick two of today's leading giants. An interesting read for those of you that are into this kind of stuff, and I am, I used to run a private equity business, is go read the Amazon letters to shareholders. Bezos starts them all and ends them all with, "It is still day one at Amazon." And what day one is four guiding principles. Number one is the customer is fanatically and seriously in the center of everything we do. Everything we do is about the customer. Apple, there's a great video on, there's hundreds of videos on the internet of Jobs speaking. And this was when they were just coming out with the first iPhone. And this guy effectively got up at a shareholder meeting and ripped him. Who needs an iPhone? What would you ever need? Blah, 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 blah. And like, it was actually a kind of a nasty question. And Jobs just sat there and very eloquently, you know, in his own sort of subtle way said, you know, I have this guiding view of the world. And that is, if I put the customer in the center of everything we do and everything we're about, if I stick the customer in the middle and everything, our culture, our being emanates from that, I think good things will happen. Today, Apple's a $1 trillion business, and Jeff Bezos is the richest guy in the world by 50%. Why? Because he put the customers in the center. If you're going to put the customers in the center, you got to know who the customers are. Now, this is a chart that my analyst loves. I don't love presenting it because it's hard to explain, but let me sort of do my best to get through it. If you take a cut at healthcare conditions in Canada by severity on the horizontal axis and by condition on the vertical axis, what you see in the middle is that big wide green thing that is mild to moderate anxiety. That's the size of the anxiety market in Canada, if you want to think of it that way. Above it would be substance abuse, and above that would be other mood disorders. Substance abuse also includes major depression. I don't know why we lumped them together, but we did. What's interesting about the customers, and when you're thinking about the patient, is not all patients are the same. There's this massive chart here, this massive amount under the curve, if you will, of people that are mild to moderate in mood and anxiety disorders, things that can be super well treated with things other than in-person care. And what that really means is you've got to recognize that people suffer differently and they have different afflictions. The GAD-7 is a measure of anxiety. GAD-7-5, mild. GAD-7-15, severely anxious. These are two very different people. Patient Health Questionnaire 7, 18, mild to moderately severe, edging on severe for depression. These people have very different needs, and they need to be looked at differently, and they need to be treated differently, and they need to be thought about differently. Because if you take this one-size-fits-all model that we're stuck ourselves in historically, and we see this in our clinics, we get people coming in at 5s and at 15s, they're taking the same human resource, the same hour, when there's no need to do that. There's no need to use that precious resource. And precious resource in our world are these wonderfully dedicated, trained professionals that just by the very nature of what they do can only see 22 people in any given week. Why are we taking these wonderfully trained professionals and having them see people that are mild? And so there are lots of companies that have looked at this, and they run into what I call the funnel trap. Okay, so what happens is they create this funnel. This is that same chart slightly differently. A lot of people mildly unwell, very few people deeply unwell. For reference, our clinics operate in those bottom two buckets. Generally is where we try to operate, all right, in the deeply unwell people. But they look at this, and as a business person or as an entrepreneur or somebody else, you see the proliferation. I don't know how many hundreds or even thousands of apps there are to, journal your depression, talk about this, do that. And by the way, they all have a use. Okay? I'm a big fan of peer-to-peer networks. They have a use. And the young man, he's younger than I am, I'm old, the gentleman who's from BC who spoke about it, who talked about it at 11 o'clock at night and 2 o'clock at night, that has a very useful purpose. But you shouldn't confuse that with treatment, because the reality is what we're finding out is light interventions don't work. They don't actually fix the problem. They, like those 4 barriers or gates, they can fix a symptom and they can deal with an issue today, but they don't long-term fix. In fact, there's some great research coming out of the prairies right now and out of the US as well that suggest that these light interventions may even do more harm than good. I don't mean they harm, but they may be net negative. And the reason why they may be net negative is for those people that are in the funnel, you tend to drip down the funnel. You don't tend to go out the funnel. Trust me, I've been there. You tend to get anxious, a little more anxious, a little more anxious, and you get in this doom loop. What happens is when I raise my hand and say, I'm ready for treatment, and I go and I do something that doesn't really treat me, makes me feel better today, solves my immediate issue. We need to have those. Those are important, especially in the stepped approach to care. Those are really important. They don't actually solve the problem. So what you find is you get into this, what I call the funnel trap, where everybody goes after that top and people avoid the bottom. And we know that because the needle hasn't moved. As we sit here today, the stats are the same. 500,000 to 600,000 people are off work because of mental health. Mental health is 30% of the disability instances, 70% of the cost. And we lose productivity in Canada, 6.3 billion. I've seen that calculation. I think it's a little higher than that, but let's stick with 6.3 billion because that's the published number. We lose an enormous amount of productivity every year. And by the way, that doesn't measure dad's time, as I call it. That doesn't measure the effect on everybody else. What we need to do is put the patient in the center, and we need to make effective evidence-based mental health care available, accessible, and affordable to all. You need to make the right care, and there's some great work, I know Nikki's here, there's some great work that's being done out in Newfoundland on making the right care available to the right people at the right time. Okay? If you need heavy intensive care, great. If you need crisis, get to the hospital. But if you don't need that, then let's not spend precious resource on it. And if you're going to do that, you got to put the patient in the center. And what the patient really needs is 5 things. They need to know exactly what their problem is. They need a rigorous assessment. We're seeing lots of things come out, and lots of people push forward these ideas where there's 10 questions on the assessment. Google put out this 9-point questionnaire. That's interesting but uninformative. If you don't know the person's alcohol and substance use issues, you don't know their family situation, you don't know some of their demographic information, you don't know what else is going on in their life, you haven't checked them for the myriad of other things, because it's almost never singled out in the middle of the field depression. It usually has a comorbidity with it. If you don't really go in depth rigorous assessment, you can't possibly know what's going on with that person. And then you need to focus on evidence-based treatment that has outcomes. This isn't about, especially for that 70% I talked about over there, you need to focus on evidence-based treatment and outcomes, because you need to know how people are progressing through. And when they're not progressing, you need to provide the support and help when wanted. That's not 1 day a week, Tuesday at 2 o'clock, skip a week, Tuesday at 2 o'clock. That's, I went home and I'm doing my evidence-based treatment. There's lots of them, DBT, CBT, other things. I'm doing my homework, and I'm doing this, and I've done my exposure theory and panic. I need to answer a question now. I don't need to wait 13 days to my next appointment. That just stalls me. The continuous improvement is important, and then finally convenience. any one of you can pick up your phone right now, and we all do it. I need you to order Tide Pods. How many can do this in less than 3 minutes on their phone? I can do it in less than 2 minutes. Like, I've got it programmed in because we seem to use a lot of Tide Pods with 6 people in the family. But the point being is I can order anything I want to order. Okay? Convenience matters today. The patient matters centric. But it also has to work for the system. It has to be effective because that's why we're here. Let's face it, we're all in this room because we want to see people get better. But it also has to have a demonstrable and real return on investment. It can't blow money away uselessly. And the reason why is because those are not sustainable events. Those are not sustainable programs. And to be effective, you must be sustainable. And to be sustainable, you must make a return. And whether that return pays back the government cost of capital, if you're a government agency, I was chair of the BDC, I understand that math. Whether that return is to do a profit, we are a for-profit business. I hope we don't wait 8 years for profit like they did at Express Scripts, but good for them for being able to sustain that. But you have to have a ROI. And you have to be massively scalable because this problem is exploding today. What's happening on college campuses? Study that came out last year of Canadian college campuses, 33% of the kids they believe in this study were clinically anxious or depressed. 13% of the kids admitted to ideating suicide, which meant I've thought about killing myself, and this is how I might do it. This is exploding. Any solution we come up with has to be scalable, massively scalable, and it has to be accountable, of course. And the good news is people are waking up. David Clark is one of the founders of the IPT in England. And I'll just read the last bit for those of you who can't. The best digitally assisted therapies can greatly reduce therapist time per patient without loss of effectiveness when compared to traditional face-to-face therapy. For this reason, IPT is exploring such therapies. They're recognizing that they need to make a change, put the patient in the center, give the patient what the patient wants. And they're also recognizing, as well as lots of studies now have come out about what makes it. And this is a little bit of a repeat of what the customer slide is. I can tell you, this is a slide that was helped by a woman named Heather Hadjivastopoulos. We have a gem for internet-delivered therapy in Canada. She's at the University of Regina. She's been doing it since 11. She is one of the world's leading experts of it. She joined our team to help us develop what we're doing. But you need to make sure that you follow the rigorous paths to get there. And what this all translates into is a patient journey. And the way a patient journey works is really quite simple. You enter into a rigorous assessment. You then, if you're effective for a tool like this, by the way, these tools are dedicated and directed at the 70%. They're not directed at the severe. They're not directed at things like bipolar that are not really dealable with in a protocol-based approach. But the tools that we can use today, the digital tools, can take that 70% bucket, deal with them very effectively and triage them very effectively, mostly out of the system for 1/10 of the price, and leave our expensive resources deal with the more difficult ones. The journey is the patient, again, gets a dedicated therapist. That's the person that works with them, answers their questions, et cetera, goes through the treatment, gets their care path personalized, measures outcomes. Therapist works with them to personalize their path. They go in a circle as they go because it's frequent that someone will enter our program with depression and then start showing signs of panic. So we simply take their next group of assignments and worksheets and start throwing in panic. And then if they develop a little bit of anxiety, we throw in a little bit of anxiety. They go through that until they're out, and then they go into relapse prevention. It's a patient journey that's done when, where, and how the patient wants to do it on digital platforms. And again, not just ours, but other digital platforms that are rigorous. It's done when, where, and how you want to do it. You don't have to leave work. It costs you very little. Most companies actually pay for it in our experience. It costs you very little to do. You do it when and how you want to do it. And the good news is this approach is now being validated. Both Health Quality Ontario and CADA issued a draft report about a month ago saying that therapist-assisted ICBT done correctly, digitally assisted, puts the customer in the center of it, delivers what the customer wants, effectively, as David says, deals with that 70% bucket. Again, I'm not trying to solve the severe one, I'm trying to try the 70% one, and deals with it. And in fact, HQO recommended that it should be strongly considered for public funding. And it not only works in theory, it works, and I promise I would only use one beacon slide. It works in reality. These are our results. 92% of our customers get at least a 25% symptom reduction on it. We average about 56%. In our world, 50% is success. 90% satisfaction on our platform, not surprised. We just put a new version in, so these platforms are evolving, small companies, and all the platforms are evolving. But the interesting thing is that I've sat with a lot of psychologists in a lot of rooms who have said, no, we have to do it the old way. You'll never get alliance. To which I give 2 points. Point number one is great for the 25% or the 33% or the 40% that will come see you. Perfect, great, no problem, I'm on it. But what about the 60 or 66% or 75% depending upon who you won't come see you? Number one. And number two is the data actually doesn't say that. What we need to do in this country is we need to take mental health care and rethink it. We need to take our limited, and we are in a scarce resource environment in healthcare in Canada, with budgets being the way they are. We need to take what we can do, rethink it, take advantage of the digital technologies where we can, segment the patient base such that when we find patients that are optimal for low-cost interventions like this, we need to put them through that and get those people onto the system, leaving our more expensive human resources, more professional human resources to deal with those people that truly, truly need it. Thank you.